Pertrochanteric fracture, intramedullary nailing with TRIGEN INTERTAN, Antegrade trochanteric nail. The TRIGEN INTERTAN nail is indicated for fractures of the femur, including basicervical and transcervical femoral neck fractures, intertrochanteric and subtrochanteric fractures, ipsilateral femoral neck and femoral shaft fractures, stable and unstable shaft fractures, segmental fractures, non-unions and malunions, polytrauma, reconstructions following tumor resection, and bone lengthening and shortening. Case presentation.
Wir haben hier eine 69-jährige.
This case concerns a 69-year-old woman who slipped on the ice and fell, sustaining a pertrochanteric femoral fracture in the right leg. She also suffered a displaced 3-fragment fracture of the proximal humerus. The dorsal displacement typically associated with this fracture is clearly seen in the lateral view. However, we shall turn first to the pertrochanteric femoral fracture, which is to be managed with an INTERTAN nail using the percutaneous technique. Patient positioning, approach, and opening the medullary canal. Place the patient in the supine or lateral decubitous position on a fracture table, depending on the surgeon's preference and/or fracture pattern. The foot of the affected limb is placed in a foot holder. Alternatively, a pin is inserted through the calcaneus so that traction can be inserted with a traction bar. The unaffected limb is extended down and away from the affected limb or is placed up in a leg holder. The patient's torso may be abducted by 10 to 15 degrees to allow for clear access to the intramedullary canal. Leg length and rotation of the affected limb are checked by comparison with the unaffected limb. The C-arm is set up to allow optimal visualization of the proximal femur in the AP and lateral planes. First of all, the tip of the greater trochanter is palpated and marked for the skin incision. In contrast with the usual practice, the incision should not be made directly over the tip of the greater trochanter, but rather 2 to 3 centimeters proximal to the tip of the trochanter and continuing for about 3 centimeters in the proximal direction, since this proximal approach facilitates the insertion of a long nail. The skin incision is followed by incision of the fascia with subsequent manual opening of the fascia. A 3.2 mm guide pin is inserted through this incision and advanced to the tip of the greater trochanter, ideally slightly medial to the tip. In the lateral plane, it should be positioned centrally to slightly anteriorly. As soon as the first guide pin is inserted, the honeycomb module can be inserted if this guide pin is in a suboptimal position. Using a second 3.2 mm guide pin, exact pin positioning can now be achieved in both planes by rotating the honeycomb module in both planes to the correct position. In this case, the first guide pin had been inserted too far dorsally in the lateral plane. The first, suboptimally inserted guide pin is then removed. After the correct guide pin position has been checked, the medullary canal can now be opened using the assembled reamer, comprising a 12.5 mm entry reamer and a 16 mm channel reamer. The alignment of the reamer should be checked under the image intensifier before the medullary canal is opened. Once the medullary canal has been opened by the fully inserted reamer, the entry portal tube with guide pin can be removed and the nail subsequently inserted. insertion of the nail, and insertion of the Intertan lag screw compression screw combination. Since the nail is not round, a press fit anchorage is achieved in the proximal femur. Next, the drill guide drop and the lag screw drill sleeve for the placement of the femoral neck screws are inserted in the drill guide handle. Here too, the skin is opened and the fascia incised. The lag screw drill sleeve is inserted through the fascial incision almost up to the lateral cortex. Adjustment of the length to position 0 is usually sufficient. In exceptional cases, the lag screw drill sleeve will need to be lengthened or shortened. The cortex can now be opened with the 4 mm drill via the 4 mm sleeve trocar and the lag screw 3.2 mm guide pin sleeve inserted. A 3.2 mm guide pin is inserted into the femoral neck through this lag screw 3.2 mm guide pin sleeve. This pin is used for positioning the load-bearing femoral neck screw. The guide pin should be placed centrally in the femoral head and neck in both planes. As soon as it is correctly positioned in the femoral neck in the AP and lateral planes, the guide pin can be advanced and the required length of femoral neck screw determined. The length can be read directly on the guide pin. Additionally, the screw length can be measured via the lag screw length gauge. In our case, we measure 95 mm. However, since there is a major fracture displacement of approximately 5 mm, we select a screw with a length of 90 mm. The lateral cortex is opened using the 7 mm compression screw starter drill for the compression screw. This step is important since the head of the compression screw must come to rest within the nail.
Now with the compression screw drill, we drill.
Next, the hole for the compression screw is drilled. An anti-rotation bar is now inserted into this channel. This bar stabilizes the fracture in the rotational plane during the drilling and insertion of the femoral neck screw in the head-neck fragment. The correct position of both the anti-rotation bar and the guide pin should be rechecked before the hole is drilled for the femoral neck screw. Since the 11 mm lag screw drill for the femoral neck screw does not have a positive stop, the progression of the 11 mm lag screw drill should be checked under the image intensifier.
You should check.
Since we have measured a 95 mm screw depth, we must drill to 95 mm. The 90 mm screw should now be inserted in the head-neck fragment to a depth of 95 mm in order to compress the fracture and avoid being left with an excessively long screw. The depth of the screw in the head-neck fragment can be read on the lag screwdriver. At position 0, a 90 mm screw is inserted to a depth of 90 mm in the head-neck fragment. At position 5, the screw is inserted 5 mm deeper. Full turns only are possible with the lag screwdriver. Since one full turn equates to 3.1 mm forward movement, the surgeon should check whether the screw can be inserted a further 3.1 mm before making another turn. The anti-rotation bar is then removed and the compression screw inserted. During the insertion of the compression screw, the handle should be secured to the femoral neck screw in order to ensure that compression is not produced at the lateral cortex immediately after the entry of the compression screw head, but only after the screw head is secured in the nail. This can be identified via the blue mark on the compression screw hex driver. As soon as this mark has reached the level of the lag screw drill sleeve, the screw is inserted far enough, as can be seen here on the X-ray. The fracture is then compressed by further rotation of the compression screw, producing medialization of the shaft until slight resistance is felt or until the fracture gap has closed. The compression screw hex driver and lag screw driver are then removed. Here you can see a schematic presentation of the fracture compression. Rotating the compression screw produces medialization of the shaft relative to the head-neck fragment. Once the compression of the head-neck fragment has been achieved, the whole construction can be switched from a dynamic to a static system. Since the set screw is already present in the nail, this does not need to be inserted. Distal locking and wound closure. The next step is the distal locking of the short femoral nail. A 4 mm drill sleeve is first inserted in a 9 mm drill sleeve via the drill guide drop, and the lateral cortex is opened with a 4 mm long AO pilot drill. Here too, the length is read directly on the drill as soon as it encounters the far cortex. A further 5 mm is added to this reading, and a correspondingly longer screw is selected. Since this screw is also captured by the medium hex driver, it cannot be lost in the soft tissues. In order to reduce the risk of shaft fractures in the vicinity of the nail tip, the screw head should not be tightened up to the lateral cortex, but a small gap should remain. The surgeon should therefore ensure that the laser marking does not disappear completely in the 9 mm drill sleeve. The drill guide handle can now be removed. The fascia is then sutured with 0 or 2-0 vicryl, and the procedure ends with the skin closure.